Hello, everybody. This is Mark Dlugoss, Senior Contributing Editor for Ophthalmology 360. Welcome to the Ophthalmic Project, powered by Ophthalmology 360. As you may or may not know, the Ophthalmology Project is a series of blogs and podcasts that addresses issues facing in ophthalmology today by offering observations and interviews with the shakers and movers in the ophthalmic field. Today, the Ophthalmic Project continues its coverage about thyroid eye disease with a panel discussion on the disease and to report on new findings that were presented at the 2021 American Academy of Ophthalmology. Dr. Kossler, one of your residents, Connie Sears, presented two papers at the AAO meeting this year. And the first paper looked at Temporal for the treatment of recalcitrant thyroid eye disease. The second was on Temporal related adverse effects in thyroid eye disease. Can you outline the findings from Dr. Sears' papers?
Sure. Yeah, that was actually our study. Basically, the recalcitrant study looked at patients that had thyroid eye disease previously treated with either IV steroids or radiation or some type of a biologic, or oftentimes a combination of the above. The reason why we looked at this patient population is that in the clinical trials that were done before teprotumumab approval, the exclusion criteria excluded patients that had greater than 1 gram worth of steroids, and also excluded patients that were previously treated with either orbital radiation or other biologics. And so we wanted to take a look at that excluded population, at that population that was resistant to the conventional therapies for thyroid eye disease, to see if they also responded to teprotumumab. And what we found, which we've already kind of said this for multiple other papers that we've already discussed, is that it's really striking how similar the response rates were to the more treatment naive population, which was studied in the clinical trials, the phase 2 and the phase 3 clinical trials. And during that presentation, we showed graphs of the pooled analysis of the phase 2 and the phase 3 study. And then we showed our kind of, let's say, real world recalcitrant thyroid eye disease patients, of which we looked at about 36 patients. And it's amazing how similar the graphs were, and even how similar they were at each time point. And actually, our patients had slightly better response at 6 weeks and even 12 weeks in some of the categories, such as improvement in proptosis, or improvement in CAS score, or improvement in overall score or diplopia score. But at 24 weeks, there was no significant difference between our patients that had previously been treated with therapies versus the more treatment naive patients from the clinical trials. And all it really did show us was that although the clinical trials had quite stringent criteria, that does not mean that patients outside of that criteria won't respond. On the contrary, these patients are responding to teprotumumab. And it's something that we want clinicians to know, because there are some questions. Should we treat these patients with IV steroids first? Should we treat them with orbital radiation first? Should we do a head-to-head comparison of teprotumumab to IV steroids? And even some insurance companies are still denying teprotumumab if they haven't been treated with IV steroids or radiation first. But what we're finding is that teprotumumab not only halts the progression of the disease, but it reverses the proptosis, it reverses some level of diplopia. And even if they have failed conventional therapies, which is unfortunately quite common, they're still responding to the teprotumumab. So I thought that was really interesting and answered a question for us. Now, the adverse event study is something that I think Ray contributed to both of these studies. I think we worked on both of these studies together with a variety of other collaborators. And what we found with that was that, in the clinical trials, the adverse events, and Ray and Erin know better than me, but the adverse events were not questioned every single time. They weren't prompted. So every patient, every time they were seen, they weren't asked, how's your hearing? How's your GI symptoms? Are you having cramps? If you prompt someone, the chances of them saying that they're having a problem are higher than if you don't. So in the clinical trials, the adverse events were not prompted, but if a patient wanted to offer up that complaint, then of course it was documented and evaluated. In our study, we looked at 133 patients, and what we found was that the overall adverse event percentage was very similar to the clinical trials. Above 80% of patients were experiencing some type of adverse event. What was different, however, was that When our patients experience an adverse event, on average, they experience 3 or more adverse events. And so each of the individual adverse events were significantly higher than the clinical trials, particularly things like otologic symptoms or hearing changes, but also things like muscle cramps and even hyperglycemia were significantly higher than the clinical trials. But again, I think that the difference there is that we're in a real world setting. We're treating patients with all levels of disease. They have been on steroids before sometimes, they've been on other treatments before. We're not every single patient is tightly controlled as you are when you're on a clinical trial or is tightly monitored. And so, the real world findings of these adverse events are that, yes, patients experience adverse events. The overwhelming majority were still mild to moderate. And I think we had about an 8% discontinuation rate, which is pretty similar to other studies. And then again, we just found that when you had an adverse event, you had multiple. The other finding that we found was just that, and this is something that we've been working here on Stanford, and I think Dr. Shriver's been working on as well, is that when you ask patients about hearing changes, you get more patients that complain of hearing changes. And so we had a significant increase in the incidence of otologic symptoms, whether that be decrease in hearing, tinnitus, or ringing in the ears, or even ear plugging, or something called autophony. And then we also found that when we followed these patients, in this study, it was only a 15-week follow-up after stopping the drug. But when we followed these patients, the majority of patients had resolution in their symptoms, but many patients still have not, and we just need to follow these patients further.
I think you bring up a good point that highlights the need for objective data when we're talking about particularly the audiology findings. So that's what we have discussed in other venues about the importance of having those audiology testing and doing it before treatment, and then if they're having a symptom or a change, then doing it as well at that point in time. And so that way you can really objectively look at how much the change is as a result of actual changes in the hearing, or if it's something the patient's just experiencing that we don't have documentation of.
Dr. Shriver, you're leading into my next question, that's involving the audiology findings on hearing loss associated with Temporal. Can the whole panel outline what you have found? So I know you've all been working on this. What have you discovered, and how serious is it?
We have a study where we looked at 27 patients that were treated with teprotumumab, and upon prompting, 22 of those patients did complain of some type of otologic symptom, whether that be ringing of their ears, plugging, or autophony, or even muffled hearing, decreased hearing, or decreased word recognition. Our study took place in the middle of the pandemic. It started February of 2020. And so, as you can imagine, getting the baseline testing, hearing testing, was very challenging for us. And so we actually only have pre and post audiograms on 6 of our patients that had hearing symptoms. And of those 6, 5 of them had a significant worsening of their audiogram findings that reached the definition for ototoxicity. And all of those patients that had a decrease in their hearing on their audiograms also had a history of baseline hearing loss. And so, it's a small study, it's an imperfect study. We're currently doing another study now with a control group where we're getting audiograms baseline 12 weeks and 24 weeks. But I think that what that study and others that have been done by other colleagues have shown us is that just as the clinical trials found, there is a subset of patients that are going to have some otologic symptoms, and if you prompt them or ask them, that number might be higher than if you don't ask them. But the only way for us to truly know if their hearing loss or their otologic symptoms is due to the teprotumumab therapy or related to it is if you have a baseline audiogram. If you only check an audiogram after they develop the symptoms, but you don't have a baseline, you will have no way of knowing if that's just age-related hearing loss or from some other reason. And most of us, as we get older, have significant declines in our hearing. So in my opinion, and what our paper and our studies have suggested, is that patients with baseline hearing loss should be strongly recommended to have a baseline audiogram prior to starting therapy, so you know at what starting point they're starting with their hearing. If patients don't have a baseline history of hearing loss, it should be recommended or offered But I think it's those patients with baseline hearing loss where it should be really strongly recommended before starting therapy. If they develop any hearing symptoms, it should be then repeated. And there could be some consideration to repeating an audiogram at week 24 once they finish therapy, even if they are asymptomatic, as we have found patients that are even asymptomatic have the definition of ototoxicity, which could suggest just the fluctuation in audiograms and the kind of the weaknesses of the way we test hearing, or it could suggest that some patients just don't quite notice certain levels of hearing loss, and so we want to check that for them objectively.
I think stressing the pre-treatment audiogram, as I mentioned, as Andrew's mentioned, I'm having all my patients do it before starting the infusions. And because I'm in the same building as the audiology testing, I'm across the hall in one of my offices, in my other office, I'm one floor down. I'm actually testing my patients now in mid-phase, so after 4 infusions, and then at the end of 8, because I feel like I have an opportunity to help us figure this out. There's a few of us, like at Stanford also, there's a good center where we work closely with Oto, so let's see if we can help get some answers. The interesting thing for me is that I had a patient complaining about hearing loss and he had no hearing changes. And then I had a patient that did not complain of hearing loss. In fact, was happy that her tinnitus improved, and she had hearing loss that was persistent and after 6 months after treatment. And so there's one thing to say, do we have changes on the audiogram? But then there's another thing to say, how much does that affect the patient's quality of life? And I think that's another thing that we have to look at, another thing that we have to better understand, because a lot of it is new for us within ophthalmology as well.
Yeah, I think that's a really important point. I feel like when this first started, everyone, when you're an ophthalmologist and you find that you're potentially exacerbating or causing hearing loss, it's extremely concerning thing for us. But now that I've worked so closely with my neuro-otologist, I'm learning that many drugs can cause either a temporary or permanent change in hearing. And when you ask the patients, many of them will say, I would rather have my vision than my hearing. I can wear a hearing aid. And the chances of it the hearing getting so bad without you checking are low. So I don't think that the message is to not treat patients because of the hearing loss. I think that we need to be aware of the hearing loss. We need to screen patients. We need to educate them, and we have to properly select patients depending on the severity of their eye disease and the severity of their baseline hearing loss. And the other thing I wanted to just say is that in our study, 100% of our patients that had tinnitus or ear ringing resolved with a 6-month follow-up after stopping the drug. And over 90% of our patients with ear plugging also had complete resolution of their symptoms with a 6-month follow-up. And the majority of our patients with autophony, over 83%, had resolution of that symptom as well. So I think that I've had a lot of patients reach out to me lately ever since our studies have been released. And a lot of people are really worried about the middle ear symptoms of ear plugging and autophony or ringing. But I think that the good news in the small amount of patients we've looked at is that I feel really confident that in at least the majority of patients, those symptoms will resolve. Hearing loss, on the other hand, only about half of our patients have had resolution of their hearing loss at 6 months, and it may just be that we need to follow them further. I do think that some patients do have true hearing loss, sensory neural hearing loss, and I do think there is a much smaller population of which I don't know the risk factors for yet that can truly have worsening of their hearing loss and can be very impactful. So I think it's an important thing to be aware of, particularly when it's objectively measured sensory neural hearing loss, and it's important to work with our audiology and maybe even ENT colleagues for those small subset of patients.
Those patients with baseline hearing loss are the ones that we're nervous about in particular right now.
Yeah, I also think that one is we have to define the at-risk patients. We've talked about a couple of risk factors, baseline hearing loss and age in mind, and we do routine audiograms also. But I think then we can also begin to think about what our term for treatment really is. Is that full dose treatment? Is that elongated treatment? Is that alternate dose? And I'm not suggesting those, but I'm saying that that's our pathway forward of identifying the patients at risk and then identifying either interventions or alterations in the treatment that make the risk benefit worthwhile.
Before we move on to other things, I wanted to touch base on Dr. Sears' papers. In her conclusions of both her papers, she mentioned it was found that protocols for screening, prevention, and management of adverse events are advised. as a panel, what kind of protocols would you like to see implemented to reduce adverse effects?
I mean, I think the main one that has, because the clinical trials covered things like pregnancy, you need to make sure that these patients are on birth control and are not going to get pregnant within 6 months after stopping the therapy. They were also pretty clear about inflammatory bowel disease and the risk of exacerbation with those patients. So I think the main addition would be to get that baseline audiogram. Patients with baseline hearing loss are at a higher risk, and to monitor those patients throughout therapy, especially if they have new onset symptoms. And so I think that the clinical trials have done a pretty good job of looking at those things and just adding on the audiogram testing. But I don't know if Erin and Ray have found other things that they routinely do for screening.
In terms of the hyperglycemia, I generally work closely with their primary care provider or whoever monitors them for that. If they're diabetic, then I definitely in communication, and if they're not, we'll get finger sticks. So that was one thing. But go ahead, I'll let you.
Yeah, I mean, the other two are hyperglycemia. We do blood sugar testing routinely after 6 weeks after their second visit on everyone, just to make sure that we're not missing anything. Certainly monitoring your hemoglobin A1C. There was, in phase 2, there was quite a generous hemoglobin A1C requirement. Phase 3 is a little more restricted. So we're still learning about that, even though it occurs at a 10% rate. And then the other is alterations in menstrual cycles, which had actually not met the 5% criteria required by the FDA upon initial phase 3, but has been added to the label. And that was only because of a sampling, just that some women had gone beyond, that time. So it's one thing that I think that I advise my patients with, especially younger women, just because it can be disconcerting.
Dr. Shriver, you've written about the use of echography to monitor extraocular muscle response to treatment for thyroid eye disease. Can you discuss how you used echography in your treatment course, and why do you think it's a beneficial tool for treating the disease?
So I have had the fortune of working at institute, both at Bascom Palmer and then at the University of Iowa, where we've had fantastic echographers. And I love the fact that they're just down the hall. I can get it. I can measure the extraocular muscles very quickly. There's no radiation, and the cost is very low for the patients, and it's very comfortable for the patients. So for me, I think it's useful as we're trying to get this idea of when do the muscles respond. At what point in time, we're talking about maybe 6 weeks, maybe as early as the first several infusions. Being able to monitor those muscles, I think is something that is a nice benefit. Dr. Douglas's team wrote a paper in BJO looking at the orbit, looking at the extraocular muscles, looking at the fat, and looking at the inflammation within the muscles on imaging, CT scan and MRI scan. So looking at those images, and it's more difficult to get those images mid-phase in the infusion, and there's more expense with it. So I thought, why don't we use our, the echographers that we have, where it's a standard practice for us to measure the muscles. The patients love getting those objective numbers. Of course, there's got to be a little bit of a wiggle room and a room for error with our 2 echographers that we use. But we found we tried to kind of actually duplicate their study, but did it with echography numbers. So we found the mean diameter of the muscles decreased 4 millimeters. Superior rectus was the largest, but the inferior rectus had a reduction of about 23%. So we know it's not just all the muscles based on previous studies looking at CTs and MRIs. But I think it's just one extra tool to use, and potentially we could gain some more information in it based on peak response time.
The muscle shrinkage or decrease in size is something that not necessarily expected at first, and it's great to see. It would be great to see the pieces filled in by Erin, along the way from beginning to end. So I think that's really helpful.
We've set a protocol where we're getting it pre, mid, and post now. So hopefully we'll have that data.
Dr. Kossler, this question is for you. As you know, whenever a new drug, device, or procedure becomes available in medicine, the topic of economics always seems to surface among clinicians, administrators, healthcare officials. You presented a paper at the AAO meeting regarding thyroid eye disease and healthcare resource utilization. Can you outline your findings from your paper?
It's no question that these new biologics are expensive. We see that in oncology and in inflammatory diseases, rheumatoid arthritis, and we're seeing that now with thyroid eye disease. And I think that's been a topic of question and debate about the cost of the drug. But I think what's also important to consider is the cost and the burden of this disease, which is extremely hard to measure. And so we were just trying to take a look at healthcare resource utilization in patients that have moderate to severe thyroid eye disease to just kind of get a sense of how much these patients are utilizing our healthcare resources and kind of what they have to go through to treat this disease before teprotumumab. And so this study was from 2013 to 2017. And what we found was interesting. Our patients that have moderate to severe thyroid eye disease in that time frame, 40% of these patients had to undergo pretty significant orbital and eyelid surgical procedures for rehabilitative treatment of their eye disease. And these are things like orbital decompression, which was the most common type of surgery that these patients have had, where Ray Douglas already said that we have to go behind the eye, we have to take down bone, we have to remove fat. And these patients, on their average number of surgeries that the patient needed to have in a year was 4. And so that's a lot for our patients to have to go through. So these patients are not only having to have surgery, but they're having to have multiple surgical procedures because of this disease. And could that have been prevented with a drug that can reverse these sequelae of disease? I don't know. But it's interesting to know what these patients have to go through. The other thing that we did was we tried to compare the healthcare resource utilization of our thyroid eye disease population to other chronic conditions. And we found that the resource utilization in these patients was higher than some more chronic conditions. And these patients are needing to go to outpatient clinics at a much higher volume than other chronic conditions such as heart disease. And so we just thought it was interesting that these patients, while they have more of a limited time period of disease, they're utilizing our resources more than other similar chronic conditions. They're needing to have surgery at much higher rates, and they're needing to have multiple surgeries in a year. So we still need to look further at the burden of this disease and the cost of the disease, but so that we can better understand, the implications of the cost of the drug. But I think that if we can stop the sequela and reverse the sequela of this disease in these patients, their need for surgical rehabilitation and for healthcare resource utilization will go down.
Panel, what are your thoughts in regards to the economics associated with thyroid eye disease? I mean, as clinicians, how do you address the costs associated with thyroid eye disease? Because it gets expensive, obviously.
It's a tough subject, but at the first is really our devotion to our patients and putting things into perspective. So what I try to do is outline what is best for the patient as far as risk and benefit. And I often think of this as the early days of rheumatoid arthritis. I wouldn't necessarily hold back treating a rheumatoid arthritis just because I could do a hip replacement or knew a great hip surgeon. So this is the same idea in that these are the early days of the economics of this disease. But at the same time, my requirement is to my patients to present all options to them, and that includes surgical options, which many of my patients still opt for, in addition to teprotumumab, in addition to even explaining what options were available prior to the introduction of the drug. So I try to paint a fair picture, and also the patients very much paint a picture of the social impact of this disease and how it's affected them. And I think that that's been incredibly beneficial to my patients on Tepezza, but also surgery, but especially in Tepezza because it occurs in such a swift period of time.
For the panel in general, as you have seen in the course of your careers, that progress is being made in treating thyroid eye disease. Hopefully, new and additional treatments and disease management options will surface to help curb this disease. In your findings and in your research circles, what do you see on the horizon to treat thyroid eye disease?
I mean, I think that's the really exciting thing about being an oculoplastic surgeon or an ophthalmologist right now, as Erin already alluded to. This is a fascinating condition and it has so many manifestations in the eye and in the body. And there's a lot of satisfaction in treating these patients. My thyroid eye disease patients are by far my most grateful patients, but they usually start off as, the most challenging at the beginning. And so it's a wonderful road that we walk together in the treatment of these patients. But it had previously been very frustrating to treat patients when you don't have, as Erin said, a good toolbox. What's been so great about teprotumumab is now I'm finally feeling like I'm truly helping these patients, and I feel really good about myself, and I think my patients are very happy. It's an expensive drug. It's a new drug. It's really changed the paradigm of treatment. But what's so exciting is that now there's all these additional drugs in either preclinical or early clinical studies. And so I think it's the tip of the iceberg. And I just, am so thankful to, Ray and Terry and Horizon and all of the people that have put so much time and energy into the education of this drug, of this disease, and into, creating this drug, because I think that now there's a lot of interest in this disease. There are at least 3 clinical studies that we're involved in that are looking at new treatment options. And I think that, 5-10 years from now, we won't have one drug that works well. I think we'll have multiple drugs that work well. And I think we may be able to choose these drugs based on patients' individual phenotypes and risk factors. So the future is really bright, it's really exciting, and I think that means that our patients are going to get, they can currently receive fantastic care, but I think it will only get better for them. So it's a very exciting time, in my opinion.
Thank you. I completely agree. And I think it's a time of all hands on deck. Any of us who are treating thyroid eye disease patients, we work together to try to help solve some of these problems and get some of these answers. Investigator-initiated trials, randomized controlled trials, looking at these new options, looking at ways that we can potentially reduce the cost, maybe not have infusions, if we can have injections or oral medications. As Ray was saying, can we reduce the dosages? Or what can we do in terms of adverse events to minimize those? So I think there's going to be a lot of work to be done in the next 5 to 10 years, and I'm hopeful. I think we have an amazing group of colleagues that are up for the task.
One of the things I think we've identified is that the underlying mechanisms do not center around pro-inflammatory molecules or the inhibition of those. And so I think that when we begin to look at the union of the IGF-1 receptor and TSH receptor and then these downstream signaling processes, that will expose a variety of potential interventions that may have very different both effects, but also potentially different adverse events, especially if we understand the genetic and the gene usage that occurs during the course of this disease and how that's influenced by the IGF-1 receptor.
Today, we've discussed a lot of information regarding thyroid eye disease. And does the panel have any closing remarks regarding the disease or any advice for clinicians who will have to treat these patients?
I think the main advice that I have for, let's say, endocrinologists, primary care doctors, or kind of the first touch that these patients may see with this disease is to think about this disease, to have it on their radar. And if the patient is complaining of these classic symptoms, pain, redness, swelling, bulging eyes, double vision, eyelid retraction, to have it on their radar, because if we can refer to an ophthalmologist that specializes in the treatment of thyroid eye disease, I think that we can truly prevent the orbital and ocular sequelae of this disease and oftentimes reverse the sequelae of this disease. And so I just think that awareness, early referrals, early treatment, patient education, that's really the game changer here for these patients. And so I just really hope that people will think about this disease the next time they see patients with one of these symptoms. And I also think it's important for patients to see a doctor that is very experienced in treating thyroid eye disease and in using all of the treatment options available, including teprotumumab, so that they can really get the best treatment out there.
We've all mentioned it, but I think this partnership with patients, educating our patients, I think you said walking the road or going down the road with the patient. Andrea, I think for me, that's the biggest thing. There's a lot we have to learn. There's a lot we still don't know. And having the patient be a partner with us through that process and through that journey, I think is really a special, and I really enjoy that part of it. And I think patients understand it very well as well.
I guess the only thing I would add is that for clinicians who hated to see thyroid eye disease patients on their schedule because there was nothing they could do, now all of a sudden it's a more palatable conversation and for both the physician and the patient.
with that said, that concludes today's Ophthalmic Project podcast. I want to thank Drs. Douglas, Kossler, and Shriver for spending some time with me discussing thyroid eye disease and the new therapies to treat the disease. So as for right now, thank you for watching and have a good day.